So hello everybody, and it's a real treat to be here. Thank you so much. I so wish I was there in person. Thank you for that kind introduction. So this is the title that has been given to me, Advancing the Integration of AMS and Infection Prevention. And I think you've heard a lot about how to address antimicrobial stewardship, AMS, and we've just heard about gap analysis and how that can help. And I've been asked to talk about advancing the integration of this with infection prevention. So just to kind of start off, I mean, just to kind of set the scene, I'll declare my interest. I think it makes absolute sense. It should be integrated. They're both public health priorities within healthcare, and they both need support and approaches to embed them within our organizations. The other thing that I think is critical, and I'm going to touch upon some of the data around this, is about the issue that the healthcare associated infection is a driver of antibiotic use. And antibiotic use is a driver of drug-resistant infection and HCAI. And I also want to just spend a moment or two talking about how COVID-19 has also affected this relationship. And then maybe go through some examples of models of where it's really important that this integration works, and also models that reinforce this integration and the importance of it. And I particularly want to consider the role in surgery and perioperative medicine. So integration is old news. It is old news, and you know, I feel I have the scars. I bear the scars of this. In 2003 in the UK, it was mandated that there should be directors of infection prevention and control, and this is really in response to the really terrible rates of MRSA bacteremia and C. difficile. And the role of the director was to oversee both infection prevention and antimicrobial stewardship. And indeed, this was then brought into a Health and Social Care Act, and so it was made law. So we were in the organization I work, we're trying to struggle about how to deal with this, and really worked with people who were kind of health systems experts and organizational experts to see how you could take kind of peripheral expert teams and embed it within the organization. And this is some of the work. I feel it's all rather historical now. Eleanor Murray led this, and she's now terribly senior in the kind of management and systems and organizational world. But it was looking at how to embed and integrate AMS and infection prevention, and make it, and by making them work together and integrate within the organization, also make them very effective rather than kind of lone wolves, you know, trying to act individually, but actually embed things within the organization and make it a part of the kind of the strategy of quality improvement within the organization. And it absolutely needs to be embedded in how we deliver quality clinical services. So we need to have organizational structures that support, and also communications and quality indicators that positively reinforce this. The other thing that I think we really need to think about within our organizations is this issue about accountability. So accountability is not just about where the blame sits, but we need clear lines of accountability also in terms of thinking about where resources lie, where you can get resources, and also where operational accountability sits rather than strategic accountability as well. And this is some beautiful work by my colleague Rahila Ahmad, looking at systems within healthcare and making the point, if it's kind of invisible and fuzzy in terms of organizational structures, it really makes it difficult to manage resource and also sustain. So the other thing that becomes increasingly more important is the need for us to look at this in a whole healthcare economy approach. both for antimicrobial stewardship and for infection prevention, and that our strategies within our hospitals align with the patient pathway more generally. And I do think it's extraordinary that we talk so much about One Health, and of course it's critical, but yet as far as we're concerned in terms of antimicrobial stewardship and infection prevention, we are working in silos within healthcare. So it's all very well we talk about One Health, but we can't even work across One Health sector. We can't work across acute care, community care, long-term care facilities, et cetera, et cetera. And we really need to consider working across the whole patient pathway and across the whole healthcare economy for both in an integrated way. So now moving on, I want to talk about this issue about the interplay between healthcare associated infections and the use of antimicrobials. And this is pretty old data. You've got the data in black from 2012, and then the later data from 2017. So my goodness me, I mean, this is pretty amazing that, you know, out of the antibiotics we use in hospital, around 20 to 25% are for healthcare associated infection. And there has been significant improvements in terms of what's used for antimicrobial prophylaxis in surgery, in terms of duration. But oh my goodness, I mean, how can that be that we are using so many antimicrobials for the treatment of healthcare associated infections? So if we were a little bit better at preventing them, it would have a significant impact on the usage within acute care. So that's UK data, well, actually England specifically. And disappointingly, I couldn't find any latest data. And I think this is a really important way of reporting our usage data to understand how much is actually being used for infections that are acquired within healthcare. Excuse me. So this is European data, and this is from the report in 2018. And again, I can't find anything more up to date. But I just draw your attention to the kind of pale blue in the middle there. I mean, those are national, each line is nationally reported antimicrobial use from European countries. And that pale blue in the middle is the amount that is prescribed for infections that actually occur in healthcare. So, I mean, if that is not an example of why we need to look at this in an integrated way, I really don't know what is. I mean, I think it's pretty amazing. But I also think this is really good data to keep an eye on, and I think it's a really important really important data for us to monitor in our own organizations. So the conclusion from this is that almost 1 in 5 antimicrobial prescriptions was for the treatment of an HAI. So just absolutely extraordinary. Perhaps if we didn't allow, you know, antibiotics for the treatment of HAIs, people's infection prevention might be a bit better. Anyway, I mean, this is really quite extraordinary, and I think we all need to do quite a bit better. But there are also then further opportunities for integration and how we can think about some of these things together. So I now want to switch to thinking about the issue of co-infections and HCAI in terms of the context of COVID. So as you're well aware, at the start of COVID, major interest in terms of massive increase of use of antimicrobials within acute healthcare. And this kind of emerged early. And of course, the focus was on acute care, because meanwhile, in the community, of course, antimicrobial usage has gone way down. And most of this was actually in intensive care, but all within acute care. And I think now we need to really shift this focus to consider the impact of COVID on healthcare associated infection more generally in the COVID positive and in the COVID negative patients, and what it means in terms of a massive backlog that we're facing. So just a little bit about the data on infections in COVID inpatients. I mean, this is just a couple of papers. We've been looking at this in some depth, but here's a summary of where we are at the moment in terms of the data on bacterial co-infections versus use of antibiotics. So. And the authors in Canada, led by Brad, are looking at this and keeping a kind of live a live review of this. But it's about 75% of COVID patients being on antibiotics, whereas the evidence is only around 8% of them have true bacterial infection. The data in England was less than that. All of the data supports that organisms seen match the local epidemiology of the hospital and the intensive care unit, and the majority represent secondary infection in healthcare associated infection. The reporting, though, is uniformly pretty poor, not reporting like days on a ventilator, days in ITU, etc., etc. And unfortunately, still very, there's a real paucity of data from low resource settings. And we still haven't got much in terms of the broader impact on our patients without COVID, but things are really coming through now. So this is work by my colleague Nina Zhu, who has demonstrated the kind of the impact on hospital bacteremias was significant. So not just for the COVID patients, but much more significant for the non-COVID patients when they were being admitted to hospitals. And this was really quite a worry. There are many authors who've reported the increase in line-associated bacteremia, CLABSIs, and the increase being seen in staphylococcal bacteremias. But this is a real issue, the impact on healthcare-associated infection, also recognizing that some of the reporting has been compromised. And then data from the US, of course, is demonstrating a marked impact on healthcare-associated infections. After years of reduction, there are major increases being seen in healthcare-associated infections. So the implications for this on the adequate infection prevention maintenance and on the importance of stewardship is really critical. So I think I'm going to move on now to thinking about examples of where it reinforces the importance of integrated antimicrobial stewardship and infection control. I'm just going to talk through a few here, and these are just examples just a few. C. difficile programs may not be much of a worry for you, but it's been a real worry for us over here. And I just want to flag how we locally have had the most fantastic C. difficile reduction management and investigation program, which has been forensically led by my colleague, consultant infectious diseases pharmacist, Mark Gilchrist. And this has really been quite extraordinary in terms of the real-time management of the patients and working in a multidisciplinary way with the clinical team, and then the forensic review of every case and the reporting of them. And this has been really a shining example of multidisciplinary work, but led by the consultant pharmacist. We could also discuss about patient pathways and preventative strategies along patient pathways. And I think we should be doing a lot more in terms of thinking about how we will be vaccinating our patients and vaccination programs for patients before they come into hospital, or making sure we catch up on vaccinations as they leave hospital. And I think this is an area for our ID pharmacists and our IPC teams to work very closely together. And I think as things change and we think about more and more vaccinations, this is going to be increasingly important. I also think the work around managing the immunosuppressed, the role of immunomodulation, which is going to be increasing, and what will that mean in terms of vulnerabilities, increases in, for instance, bacteremias related to neutropenias, etc., patient prophylaxis, when do we need to think about antifungals, etc. And all of that needs the data behind it, as well as the input from our colleagues, our expert colleagues in antimicrobial usage and clinical pharmacy. So the work of screening and generating data. So screening for AMR carriage, surveillance, and hospital epidemiology all form the bedrock of how to inform practice, policy, interventions, rapid responses. And this is for infection prevention, but also, of course, for antimicrobial policies and monitoring. And it's really important that this management of data and the monitoring of data, and indeed it feeding into policy guidelines and into decision support, needs to be integrated between infection prevention and antimicrobial stewardship. So I'll now just move on to thinking about surgical pathways and perioperative medicine as a particular example of where I think we could do much better and where there's major opportunities to look at this. So Asmita Charani, my colleague who is our senior research pharmacist, has had a particular role in looking at this and leading this research, and she's got a major background in looking at the kind of social sciences and their application, both in how we use antimicrobials, but also how we approach infection prevention. So this is some beautiful work about why we really need to think about surgeons, surgical pathways, and surgical teams in more detail, because they are different medical teams. They work in different ways. And it's really important that we recognize this and work around to support this. And I want to introduce and discuss the concept of perioperative care and how we could perhaps use this much more to address the management of infection and use of antimicrobials. So we're very lucky to be involved in a large study that involves South Africa, Rwanda, India, and the UK to look at how we can improve the use of antimicrobials and infection along the whole surgical pathway. And this is very interesting work, and it also has yielded the kind of complexity of the surgical pathway, but also the areas in which we can focus on to address infection prevention, infection management, and the use of antimicrobials. And of course, that doesn't all happen within the ward. We need to think of before, after, and the whole pathway. And if we don't do that, we really are missing some opportunities to involve key people and also make a difference. So I mentioned perioperative care. I want to introduce you to somebody who is a real leading light in this globally, Ramani Munasinghe, who is working very hard on promoting this role of perioperative medicine and patient safety. And the role of the anesthetist and the anesthetic assistant in terms of not just managing the patient during their time in theatre, but also before and after, is really, really gaining traction. And I have to emphasize, of course, this is not just for managing infection and managing sepsis, but also for managing issues about cardiovascular issues, management of diabetes, etc. The medical management of the perioperative patient could perhaps be done a little bit, could perhaps be rethought in terms of providing continuity across the whole pathway and the concept of perioperative medicine. So we're very interested in this, and there's been much work around this. and this is a paper in IJID working with surgeons and anaesthetists and implementation scientists about how this perhaps could be used a little bit more. Also qualitatively thinking about where to go in terms of having an impact and effect to reduce this massive burden of infection related to surgery. And I'm not just talking, of course, about SSIs, but I'm talking about any infection related to surgery. So one particular aspect of this is, of course, the role of the surgeons and the role of the patients and their carers. And there is much untapped opportunities and resource there that is that could really contribute to improving clinical outcomes as well as raising awareness. And there's some beautiful work being led by a colleague in Cape Town, Aluchin Balu. I think there's much more that will be able to be done there. And I also think this, of course, will be helping with a more broad engagement with society in terms of awareness around infection prevention and the use of antimicrobials. So I think this is an area that really we can be promoting, and it's a real pleasure to be working with leaders in the field in anesthetics and perioperative medicine to see how we can explore this a little bit more and integrate antimicrobial stewardship and infection prevention along the surgical pathway, and using clinical leaders, not necessarily professors of microbiology or lead infectious diseases pharmacists, but how we can work with clinical leaders to support this and work with our surgical colleagues. And I think this may be very interesting indeed. So I'd like to thank all of my colleagues, but I would particularly like to thank all of you for listening to me go on just now, and it's a real pleasure to be here. Thank you.
Professor Holmes, thank you very much for your lecture. I would like to remind the audience to submit questions. I would like to start with the one question that's related to COVID. A year ago, I thought that with the unprecedented fear-driven improvement in hand hygiene and use of PPE, we will see less hospital-acquired infection. We will also see less antibiotics because it's largely viral infection. What we see is exactly opposite, more antibiotics and more hospital-acquired infection. What do you think went wrong? Why did that happen?
Yeah. But what opportunities maybe for learning now? So I think I'm going to I'll take the antibiotic side first, if that's okay. So I think things are much improved, and I have to say, I mean, I didn't show data about how things have improved, but you know, initially masses of antibiotics being used, and then the guidelines came out about that, you know, very little was bacterial co-infection, and indeed most of the bacterial co-infection is related to secondary care and duration in ICU. So I think the antibiotic usage has changed dramatically from when COVID first hit. So I think the stewardship activities, certainly when we are, have had a major impact. And that has been significantly reduced. When I mentioned immunomodulation and I mentioned infection risk, goodness knows what are we going to be thinking about in terms of antifungal prophylaxis if we're going to be using more and more immunomodulation. But I do think lessons have been learned around antimicrobials in acute care, and certainly, as I said, we've got data to show that. What I think is interesting, though, is that we were worried about antibiotic use in acute care and its increase, but there has been a major fall in antibiotic use in the community. So goodness knows what all of that is going to mean for AMR, and was all that reduction appropriate? So we need to look at this all together. Then And that's what I'm saying about whole sector approaches. Then your other point that you raise, which is so true, which is you think, my goodness me, you know, a real opportunity to reinforce good infection prevention practice. However, it was at a time of such utter turmoil and churn and not enough healthcare staff. And, you know, and the issues about PPE. So, I mean, one of the things in the paper by Nina Zhu that is highlighted is that, you know, we know bacteremia within ITUs is also strongly related to staffing levels. Well, I mean, my goodness, you know, we went from, you know, 1-to-1 nursing to 1-to-6, you know, so and in very, very difficult circumstances. And I think, you know, we have to acknowledge that and the impact that that has subsequently on the on what's happening with infection in the unit and the non-COVID patient. And certainly we're seeing some interesting outbreaks of organisms related to that, how our health service was really challenged during that time. Excuse me.
Thank you very much. I have the question from the audience. What is your advice on convincing healthcare leaders who may not be familiar with AMS, HAI, to invest resources in this area?
Oh, I think, yes, I think we all have a role in that. And I think we're very lucky to have some very energetic political leaders or persuaders. I think it's really interesting that the economic argument worked so well. I mean, so the, you know, it's interesting that so many of us have been saying things for quite a while, but it's a kind of report from an economist like Lord Jim O'Neill that really raised the profile in terms of political attention. I do hope I do hope actually the pandemic will actually help raise awareness about how this is so absolutely critical. I also think in terms of managing the backlog of elective patients and the risks of drug-resistant infections, etc., will also be will sharpen focus too. And I think we need to kind of learn what's worked and what hasn't worked in terms of climate. And one of the things that we need to think about is really strong societal engagement, because our, you know, politicians will come and go, but it will be up to the young and society to say, you know, we care about the planet, but we also need to have a functioning healthcare system. And for that, we need antimicrobials that work.
Another summit in Glasgow, perhaps.
Yes, perhaps, or yes, or another city, another.
Any questions?
Sure. I may bring up a question that was for you that was raised earlier, but when we didn't have a live professor to ask. This was a question similar, a little bit similar to the first one, but it's you know, there's a lot of feedback in audit with ASP, and what do you recommend when the team or that certain specialty doesn't you know, accept the recommendation and doesn't want to de-escalate or, you know, stop antibiotics?
So some of the stuff I was touching on at the beginning of my talk is to actually help us with that. And if I do not think the kind of performance in terms of appropriate prescribing should sit with the antimicrobial stewardship team. It's their lead strategically, but in terms of if you're doing any performance monitoring or quality metrics, the delivery of those sit with that unit, department, division, or however it works in your organization. So ultimately, it will not be the antimicrobial stewardship team that will be, you know, haranguing them. It will be their line managers within their own service. So, you know, do what you can, but make sure that the structures for performance management, quality metrics sit where line management actually has clout. And so I would do, that's something that's really important. So it also helps with, you know, sustaining the kind of momentum around the quality improvement when it's, you know, you're not caught up all the time with chasing your tail about, you know, what people are actually doing, because the monitoring of that and the accountability for that sits in their team, their division, and ultimately within the hospital or health system organization.
Great. So that raises the issue of bringing it to a leadership level. Thank you.
Absolutely. And embedding it in quality care. It's, you know, you develop your metrics, keep them, and then it's, you know, the division, department, whatever section will have to report to them, to your board, you know, and you integrate your antimicrobial stewardship metrics and your infection prevention metrics into your quality dashboard for your organization. And then the accountability for that sits with however you organize things within your particular your particular healthcare system or unit. Or
thank you very much for your lecture, and thank you very much for your comments and answers to our questions. I am getting these signals that we are running out of time, so thank you very much, and we will now move to the next section. Thank you again for your talk.
I